Hello everyone, this is Dr. Davis again. This is our last part of the high risk module. This is all about high risk baby. Okay, so these are the same objectives from the other half of this lecture. We are going to cover all the baby part of it on this in this section. So any of these that pertain to our baby, so identifying your high-risk baby, care of the high-risk baby, what babies are high risk, um, taking care of a diabetic baby, babies with fetal alcohol or NAS, and then hyperbilirubinemia. Okay, so a few things that we need to think about when we are caring for a baby. Um, so, um, Babies that require special care at birth. Usually about 60% of those we can identify while mom is pregnant, okay, because we're able to do quad screening and we're able to do sonograms and we're able to do other testing if we think that there's an issue with this baby. Usually about the other about 20% we'll be able to tell because of risk factors that are happening during the pregnancy, right? All of a sudden I am now a gestational diabetic. All of a sudden now I have high blood pressure. So things that happen during the pregnancy, we'll be able to identify those. So that still leaves us 20% of those babies that could have issues when we don't really know, okay? I have had quite a few deliveries where baby comes out, physician hands this baby to me, and I'm like, well, what in the world is going on here? Okay? Had no idea. Now, is that because mom didn't get any prenatal care? Possibly. So you always have to be prepared for everything, okay? Um, Babies that have an APGAR score of 7 to 10 are those that really don't need any kind of resuscitative measures. Because remember, we talked about APGAR scores. 7, 8, 9, 10 are all um, really good APGARs, and we don't necessarily need to do much to them. Maybe I'll need to aggravate them a little bit, make them cry, but other than that, we're okay. Okay, scores of 4 to 6 are telling us that there's mild to moderate asphyxia of some sort, and 0 to 3 scores indicate severe asphyxia. If I um, have a baby that comes out and doesn't look great, I'm not going to wait till the 1 minute APGAR before I start doing something. Okay. I'm not going to stand there and just look at the baby and see what it's doing. I'm going to start working with that baby. Okay. I'm either going to get a baby straight onto mom's chest to do skin to skin, get them dried off. In the drying process, we aggravate them a little bit, make them cry. Those are good things, okay? So I'm not waiting until that 1 minute. And if I see a baby that looks to be severely compromised, I'm really going to start doing something, okay? Any APGAR of less than 6 at 5 minutes requires that you do another assessment at 10 minutes. So if my APGAR score was um, 2 and 6, then at 10 minutes, I need another score. And those should be coming up, or else I clearly have a baby that's very compromised. Um, Now, having families there with you in the delivery room, it can be very hard to deal with babies that are having problems. But typically, if I think that there might be an issue with baby when it's born, then I'm going to tell mom and dad that we can just only have the two of you in here because I'm going to have to bring in a lot of other people, and I need to be able to take care of your baby the best that I can. And that may mean not having grandma, Aunt Sue, brother George, my neighbor, and their children. Okay. So those are some things that we need to think about when we're caring for our babies. So a few more of the danger signs that you might see in a baby that we need to recognize are when I'm thinking about my central nervous system, I might see lethargy, I might hear a high-pitched cry, jitteriness, seizures, or bulging fontanelles. With my respiratory system, I may see apnea, which is a lack of breathing, tachypnea, flaring nostrils or nares, retraction, seesaw breathing, and grunting. Cardiovascular, an abnormal rate and rhythm, a persistent murmur. Sorry about that. Differentials in pulse and blood pressure, I'd like to add there. Dusky skin color or circummoral cyanosis. So in babies, you can do 4-point blood pressures, which means you're going to do them on both arms and both legs. So if you do it and or hear a murmur, um, then your physician's going to ask you to do a 4 points. And basically, they're looking for a difference between the upper extremities and the lower extremities, or a difference between the left side and the right side. So that's what they're looking for there. Gastrointestinal, so maybe I don't have good feeding reflexes. I may have vomiting, abdominal distension, change in stool patterns. So sometimes like our C-section babies, because they don't get squeezed on the way out, they'll have swallowed a lot of that amniotic fluid. Sometimes they swallow some blood. That makes their stomach they're a little bit nauseous. So they do a lot of gagging and puking. Usually if they'll go ahead and puke a couple of times real good, they'll feel much better and then they'll be able to eat. If not, then it's just this really delayed kind of process of gagging. Um, so sometimes the pediatricians will allow you to do some deep suctioning, and you're actually just going to drop a suction catheter, a very tiny one, obviously, and suction out that belly, and it just gets out all that fluid and old blood and stuff like that, so that they can then move forward with their eating. Um, their metabolic system, so we may see hypoglycemia or calcemia. We may see hyperbilirubinemia, which is jaundice. We may see a temperature that's up and down. We want to make sure that our baby stays warm. If for some reason your baby is really cold, you're going to warm this baby up slowly. You don't want to just put them under a really warm baby warmer. Sorry, guys, I'm at home and the dogs have noted that the wind blew or something. Who knows? Um, Babies also have little glycogen storage, so they will need to be fed more frequently. So you want to anticipate that the NCLEX is going to ask questions about normal newborn reflexes. They're going to talk about physical assessments, which are normal characteristics, and how to differentiate between caput and cephalohematoma. So we will talk about all those things more in class. Okay, so our last lecture ended on taking care of a diabetic mom while she is in labor. So this is going to be baby. What do I need to do to take care of baby of a mother that has diabetes? So remember, or let's think about. So my baby is living in this environment where there's a higher glucose level. Um, than normal, right? Because that's how this whole thing works with diabetes. So let's imagine that my baby is in uterus and has a lollipop, so a sucker. It's sucking on this piece of candy constantly for 10 months. Okay. You, this baby is born, and now I no longer have that readily available piece of candy that I'm constantly sucking on. So that would be quite a big change for this baby system. And on top of that, my liver is immature. All the other things that are supposed to help control the sugar levels are immature. So I can't manage this on my own. Okay. So we are going to have to then step in and monitor baby very closely and have some interventions ready for these babies. Okay. So sometimes a mom with diabetes, you're most of the time you're going to see a very large baby. So this baby's going to be macrosomic. Okay. So it's going to be large for gestational age. Now, if my placenta isn't working from issues with diabetes, that's a different story. So you may have a very small baby, but not most of the time. Okay. Most of the time, you're going to see these little chunky monkey babies. They're super cute. You just want to squeeze them. All right. But the fluffier the baby, the harder it is to start IVs, to draw blood, to get them to eat. Okay, so these cute little fat babies come with lots of other issues. Um, so typically they're going to be hypoglycemic. They can be hypocalcemic. Um, Hyperbilirubinemia is jaundiced. So I might be jaundiced. I might have polycythemia. There may be some sort of congenital anomaly. I can be born with an infection and sometimes be premature. And sometimes these babies are early because we need to deliver early, so they're premature, but they're still a chunky little premature baby. So don't let their size fool you. We still have to look at how many gestational weeks is this kid, because you might be a 9-pound baby, but only be 34 or 35 weeks. So those are things that we have to think about when we're assessing our baby. So what things, what nursing interventions do I need to be prepared for? So a baby that is macrosomic, large for gestational age, any of those things are at risk for birth trauma. Because remember, mom's pelvis, while it might even be a totally normal size pelvis, if I have a totally huge baby, it's going to be hard for that baby to come out. So there's a possibility that if I do deliver vaginally, that there's some sort of a clavicle fracture. There can be some neuro trauma. There can be um, all different kinds of things that might happen with this baby. So we're going to be watching for that. Okay. So at 30 minutes of age, that's the first thing I'm going to look at is for any signs of birth trauma. Then the next thing I'm going to do, of course, we have to do our normal assessments. These are on top of our normal assessments. Okay. So we're not forgetting about the breathing and the heart beating and the blood pressure and all that kind of stuff, right? Because we have to have those things or it doesn't matter what my heel stick is. Because um, if my heart's not beating and I'm not breathing, who cares what my sugar is? Okay. So these are all on top of a normal assessment. So at 30 minutes of age, we're going to do a heel stick and see how that baby is doing. And then we'll do it again at 1 hour. Typically sometime in there, baby will breastfeed. And usually what we have moms do is call us before they're going to breastfeed and we're going to check a blood sugar. Okay. Typically we're going to do these for the first 24 hours before every feed. We're going to check that sugar and make sure that baby's maintaining. If baby's not able to maintain that blood sugar in that normal range, which was 40 to 60, then we may have to feed baby earlier, or it's possible that we need to um, start an IV if we have to, okay? Usually that's our last step. We try to fix hypoglycemia with um, food, okay? We try to fix it with either formula or breast milk, either one. We will observe for hypoglycemia and hypocalcemia. Both are jitteriness. You're going to see a very jittery baby. Um, so how do I know the difference? Well, I'm going to check the blood sugar if I see a jittery baby. If my blood sugar is within normal limits, then I'm going to call and get an order for some lab work. So that's how I'm going to know the difference. And then we're going to start small, frequent feedings, usually about 1 hour of age. If I'm breastfeeding, that's fine. If not, if I'm formula feeding, then I'm going to give them a small amount of formula. Um, an ounce of formula is about 30 mLs. Um, Usually we start babies at 15. So babies eating formula do not eat more than 2 ounces at a sitting, okay? Not at first. Their tummies are very small. So if mom feeds that, we'll give them a bottle, and usually there is 2 ounces in the bottle. But if they eat all of that, they're going to be puking their little guts up because they're going to be overfull. So those are a few things we've got to look for when we're taking care of these babies. Okay, so a baby that is septic. So what things am I going to see? Lethargy, temperature instability, difficulty feeding. Sometimes I'll have some mottling, or their color will be dusky. Change in behavior, respiratory distress, hyperbilirubinemia. Typically with your neonates, you're going to see not a temperature increase, but a temperature decrease when they get sick. So sometimes if baby's all wrapped up, should be perfectly warm, there's no reason why it should be cold, and you take their temp and they're cold, that's one of your first signs that maybe we need to watch this baby a little bit closer. So how do we prevent infection in your high-risk newborn? So maybe I'm taking care of a preterm baby. So these are some things, but you would do this with all of our babies, right? We're going to wash our hands. When we start the beginning of each day, they usually ask you to do a good scrub, almost like an OR kind of a scrub at the beginning of the day. And then in between each baby, you're going to want to wash your hands. You're going to be applying something to the cord. This mentions triple dye antimicrobial. Some places do that. Remember, we talked about some places do alcohol, some places do nothing. So that just really depends on where you're at. Of course, if we're doing a sterile procedure, we need to maintain that. Um, Typically, we avoid wearing rings and jewelry in the nursery, and absolutely no artificial nails. Um, they may go even as far to say that you cannot wear fingernail polish. They do tell you that your nails have to be short. Um, so that's another thing. Always be careful when you're dealing with a baby and wear gloves. We're going to look at that IV site for sure every hour. So your IV pump is going to be set to beat every hour, and you need to go and look at your IV site because it's very easy for those to slip out of that vein, and then you're just pumping fluid into the extremity, and you can really have some issues with that. We want to use as little tape as possible. They have a lot of um, different devices that you can use where you will use some Velcro and different things if you need to be taking um, things off and on. So say my IV site for some reason, or I need to be able to change the tubing out, whatever you're doing, they do have little strips of Velcro that will stick to baby, and then the other pieces are the opposite part of the Velcro, and that just keeps you from having to tape and untape to their skin. Same thing with it for their face. If they're getting oxygen, they'll have some little strips that they put underneath those oxygen tubing, and then you tape to that. That way, the only thing that's on their skin are those small little pieces. Um, we want to make sure that um, anybody that may have an active herpes lesion, so either um, on, on my lips, we're obviously not kissing other people's babies. If they do, they have to really be careful with that because we don't want to spread that to babies that are already sick. And then we are going to make sure that they're getting adequate nutrition. So, excuse me, some of these little preemie babies may be in the unit for quite a while, so they may not get protein feeds right away. They may be just getting some IV or OG nutrition, depending on how long they're there. They try to do breast milk if they can, but that really depends on how far along baby is and if their gut is ready to handle protein feeds. So if we suspect that a baby may be septic, um, this is telling you that we want to put the baby in an incubator or an isolette. Typically, the protocol is for the baby to go to the nursery, and they will be in a radiant warmer of some sort for that way the nurse and doctor can go ahead and work on baby. And then if they need to, if baby's really premature, then they will put them in a kind of an incubator type thing. Um, we're going to do a blood culture, urine collection, chest x-ray, chemistry, a CBC. Now, as far as spinal tap, they don't necessarily go there that quickly. Usually that's kind of a last resort kind of a thing. Um, in my experience, I haven't seen that many done on neonates. So it can be done. I just haven't seen it done frequently. But we definitely do blood cultures, collect urine, do ABG, a CBC, x-rays, that kind of stuff. And then once we get all that blood work done, then we'll get started with our antibiotics. So you're going to learn when you get into peds that pediatric and neonates dosages of medications are done by weight in kilograms. So please know and understand how to convert those if you're not doing really great with them, because typically what you'll get is ampicillin 1 gram, which is totally not right, but 1 gram per kilogram per day. And then you're going to have to figure out how much they can have. So definitely get comfortable with doing those kind of things. I know for pediatrics, that's how all their meds are given as well. And then we'll draw peak and trough on those drugs just like we would on an adult, looking for the therapeutic level and making sure that that's achieved. Okay, when I have a baby that I'm going to be putting on oxygen therapy, we're going to start at the lowest possible concentration. Um, they will definitely use an oxygen analyzer to determine the concentration. What I want you to remember is that oxygen is considered a drug, okay? Meaning you cannot just start it because you feel like it. You need an order for it. Now, if you're in a resuscitation situation, that's a whole different story. I'm talking about, after baby is out, we're not in that, short stay kind of a thing. And now I'm concerned about the oxygen level. Of course, if you have a baby that is blue, you're going to put oxygen on and somebody's going to be calling the physician. So I'm not saying that. I'm just saying that we have to be careful when we just start oxygen. Okay, so they have found that there is a correlation between oxygen use in the hospital and these babies, especially preterm babies, having eyesight issues later in life. So there's some studies that have been done about that. So they're very cautious when we're doing oxygen for a baby. Surfactant is a medication that can be given. It's something that should be already in your system. Surfactant coats the lining of the lungs and the bronchioles, all those little tubes and alveoli sacs, all that surfactant is in there. So what happens is, especially with our preterm babies, that surfactant's not been developed. So the lungs and all those little air sacs stick together. The think of surfactant as like your cooking spray. So you know if you spray a pan um, to make a cake, you spray your pan. When you get done, you should be able to flip it over and it falls right out. It's good, right? If I don't put spray in there, the whole cake sticks. So it's kind of that same kind of a thing, all right? It's like your cooking spray. So without it, all those pieces of my lungs are just stuck together, okay? So sometimes they will come in and give surfactant. The only way you can give surfactant is through an endotracheal tube. So basically, they have to have the baby intubated. Then they shoot the medication down the tube, and then they literally pick up the baby and tip them all in all different directions, basically moving them around to move the surfactant around in their lungs. Okay, it's a bit of a traumatic experience, both for the nurse that's taking care of the baby and the baby, because if I'm shooting fluid down into somebody's endotracheal tube, I'm going to feel a bit like I'm drowning. So there, it's hard for those first few minutes. Um, kind of watching baby gasp and all that stuff, but they do get better relatively quickly with the use of surfactant. So things we're going to monitor for, we're going to look for respiratory acidosis. Is there any kind of organ damage, including brain damage? And then sometimes you can get necrotizing enterocolitis or NEC. It's a hypoxic ischemic injury of the intestinal tract. It can result in sepsis and in death. I did have a friend of mine who had very preterm twins. They were fed rather early and both of them ended up with this and they both passed away. So we have to be very careful with what we're doing for our babies. All right, hyperbilirubinemia, also known as jaundice, and that's what I'm going to call it from now on because it gets to be quite a bit to say. So there's two different kinds of jaundice, physiological and pathological. So physiological jaundice happens with after the first 24 hours of birth, and it's caused by an increased bilirubin. Um, the organs aren't able to break down all the erythrocytes, all the bilirubin that's hanging out in the bloodstream. So then I start getting yellow. So you'll notice the whites of my eyes might be yellow, my skin might be yellow. So that's something that we're looking for. If it's pathological, that jaundice can be caused by hypothyroidism or a blood type incompatibility. So in this case, when I'm talking about a blood type incompatibility, it typically is the O positive moms that we have to watch for. But we'll also test the Rh negative moms. Okay, so the moms that are Rh negative, those babies will get tested. So I'm testing the baby once they're born. we'll send down when they're about 12 hours old, 6 to 12 hours old. We'll send down a CMP and ask for a Coombs test, and it's going to tell us if what is baby's blood type, and if it's elevated, then we're going to go ahead and start treating jaundice. Um, so that is something that we're going to look for um, with our babies. All right, so um, this jaundice either way can cause kernicterus, which is brain damage from the increased bilirubin, but we're going to talk about those in the next couple of slides here. Okay, so excessive amounts of bilirubin in the blood um, causes the bilirubin level to be increased, right? Thus the hyperbilirubinemia, and therefore causes jaundice. Now, how do the baby's bodies get rid of this? So there's a few ways. Typically in adults, it's something this is done in the liver. The liver cleans out these the bilirubin and all this other things. Excuse me. In babies, those organs are very immature, so I'm not able to get rid of it. So the best way to get rid of it is to increase the feedings. When I increase the feedings, that means that I'll increase the voiding and stooling of the baby, and that's how they're going to get rid of this bilirubin. So if you've had a baby that has had jaundice, they will, you can tell as a baby starts to get rid of it, their stool consistency changes, it changes to a different color, and you can see that it's actually working what we're doing, okay? Of course, we're also going to do some phototherapy, but we'll talk about that on our next slide. So they can get jaundice, which is where you will see the skin is yellow. You'll see in the eyes that the eyes are yellow. You can get kernicterus, which is what I mentioned on the last slide. That is encephalopathy, and it results from bilirubin being deposited in the brain, and it can cause some damage. So we don't want to go there. Okay. We're going to assess the skin for damage. You can look on babies if you apply pressure over a bony prominence. You can see the yellowing of the skin. But typically what we're doing is they have the one we used was called a Billy check, but it's a small little machine that actually measures the level of yellowness in the baby's forehead. So we will do those. That was part of our assessment. You did those with our morning assessments. Everybody got a Billy check, and then we plotted it on a grid. So all of that we will talk about in class. I'll kind of show you how that works. Usually the best places to assess is, this is a nose, forehead, and sternum. You can see it on the nose, especially if you press down on their little nose, you can see the underlying yellowness. But for sure, forehead and sternum is what we use for the Billy check. Normal jaundice usually occurs within 2 to 3 days after birth, and you will start seeing that baby looks a little bit yellow. So that's what we're trying to stop, is because typically at day 2 or 3, baby's already home. Then you had moms that have to bring baby back and stay a couple more days to help get rid of the jaundice. So we started doing the Billy checks every day, even if baby's only 2 hours old. If it's an 8 o'clock assessment time, then I'm going to do the Billy check with it. Then I'm going to catch these babies as they start going up. Their level starts going up. We treat them right away. We don't have to, the babies usually don't have to come back. So it's a much better system for treating. Okay, so this is the other big treatment for um, jaundice is phototherapy. All right, so this little dude is chilling with his sunglasses on underneath the Billy light in an incubator. So things that we have to think about if we're doing phototherapy. So phototherapy, the idea is it helps break that bilirubin down in the skin. So you're getting phototherapy, we're increasing feeds, so we should have an increase in voids and stools, and you're going to see a change of the in the stool and sometimes even in the urine. The urine may change to an orangish color if we're as we're trying to get rid of this bilirubin. Okay, so this is one type of phototherapy. They also have Billy beds. The next slide is a picture of a Billy blanket. So I'll show you what that looks like. They do have some home um, phototherapy that can be done as an outpatient, but typically they prefer to just bring baby in um, because especially if baby's a couple days old, because that level might be quite high and it may be possible that baby might need an IV to get some IV fluids in to get them going. Okay. Um, when we're putting baby on phototherapy, we have to make sure that that light's about 18 inches above baby. They do get warm. They're very similar to tanning bed lights. The difference is there's not going to be any of that harmful UV rays, so baby won't get a tan. Um, but it will give you, as the parent, a ginormous headache. Um, you'll notice if you're in the room with um, Billy lights, with these phototherapy lights, um, that if you being in the room, it's this overwhelming blue color. When you go out and say into the hallway, everything is tinged a very funny yellow color. So mom and dad that are in the room, I tell them if they start getting a headache, they need to put sunglasses on because the lights can be quite bright, and sometimes we'll put two lights on a baby. We'll put one above and one kind of slanted on the side if baby really needs to get this bilirubin down. We try to do this before we put babies on any kind of IV fluids. We want their body to do it as best as we can without doing any other interventions. But it's possible that they have to have some IV fluids, okay? So we're going to want to make sure they have their little eyeglasses on. Now they have a Billy bed. I believe I have a picture of it for you to see in class. But basically the bed is underneath the baby, so the lights come from the bottom, and baby is actually put in what looks like a large onesie that kind of contains the light. And then that way the baby doesn't necessarily have to keep these eye patches on constantly. Because remember, they do have that grasp reflex, and so what are they going to do all the time is pull those little masks off. So you have to be careful and make sure that they stay on. um, they're good at really wallering them off. They they just don't like it on their face. So we're going to keep their bottom covered with a diaper, but other than that, they're going to not have any clothes on because the more skin that is open to that Billy light, the quicker this is going to move. Um, We're going to turn baby every 2 hours. This is a really, really hard time for mom and baby because maybe up to that point I've been able to hold my baby, and now the more this baby is under the lights, the better. So I may be only able to take baby out to breastfeed and put them right back. If baby is bottle feeding, I usually encourage mom to just feed baby underneath the lights and not take them out real often unless they have to. Just because the more time, the faster this will break down and work. So it can be very hard. If you have a fussy baby, it's really hard to listen to your baby fuss while it lays under the lights. But there's really nothing that you can do to assist that, except sit and hold a passy in their mouth. Um, we're going to turn the lights out, so we will bring baby out, we'll do assessments, give them a break from the lights. We're going to watch baby for signs of dehydration. So remember, we want baby to pee and poop out all this bilirubin. Being under that light can be very drying to the skin, so we want to make sure that we're not voiding and stooling too much, that we're making sure that we're taking in what we need to. Um, the lights can increase the risk for dehydration, so we want to watch that for sure and make sure that the feeding is going okay. If feeding is not going okay, then we definitely are going to have an IV for this baby. So this is a version of a Billy blanket that can be used at home. Of course, this is in a hospital setting that this baby is being treated. So we still want to um, be very careful with our baby. If they need more than just this one light, then they may need to come to the hospital for some extended monitoring. Okay, so the last two slides are really about abstinence and substance abuse in babies. So NAS is a big one that you're going to see. You're going to see it when in peds. You're going to see these babies on the peds floor. If you get to go to the nursery, you're going to see some of these babies in the NICU. So neonatal abstinence syndrome is a syndrome that happens when these babies have been had a prolonged exposure to narcotics of some sort. So that is the babies that have the hardest time with this. If I'm using illegal substances, if I'm using prescribed substances not used appropriately. So my hydrocodones, which were Lortabs, it's now Norco. Um, any of the oxycodones, oxymorphones, any of those different kind of prescribed medications, but they're being used not appropriately. That this is one of the reasons why we try not to give moms any kind of narcotic during pregnancy, because you're at risk for having a baby that has to withdraw from the medication. Because remember, if mom is having to withdraw from medication, the baby also has to withdraw from the medication. Okay, so this baby's going to be irritable. It's going to be hyperactive. They have the worst high-pitched screechy cry you've ever heard. It's awful. You can hear it down the hall, and you know for certain that this baby is an NAS baby. They're going to have tremors. So in class, I'll show you a video of these tremors. Um, they are poor feeders, but they want to suck constantly. So um, they vomit and have diarrhea. Their noses are very stuffy. Um, Things that we can do for these babies is swaddle them. We try to leave them alone as much as possible. Don't be bothering them all the time. Try to decrease the environmental stimuli as much as possible. We're going to give them a pacifier. We may put them in a prone position, but that's going to be if somebody's there where they can be monitored. We're going to watch elbows and knees for skin breakdown. So why elbows and knees? These babies, they will um, draw up their arms and legs very tight. You can almost, sometimes they'll be so rigid, their little arms and legs in a flex position that you can lift them up with just holding onto their arms because they're just holding them so tight. And then they rub those elbows and knees against the blankets, and so they can have some skin breakdown. You'll want to have a bulb syringe close at hand. We will do some scoring and we'll talk about how that works in class. But these babies really have a difficult time. Um, they we will score them to see where they are at in their withdrawal process. If the numbers get worse and worse, um, what happens is they're going to have an increase in breathing, increase in heart rate. I have a poor feeder. So eventually I'm going to get to the point where we have to treat them. So sometimes they get to the point where we need to give them liquid morphine. It's PO. But these babies will have to stay in the hospital until they're completely off of the medication. Okay. A couple of reasons. You're giving babies liquid morphine. I can't imagine as a parent having to bring one of these babies home um, because it's hard enough for nursing to deal with them because they're just so cranky and irritable. Um, I can't imagine the outcome of sending this baby home with someone who has some addiction issues, um, and then sending them a liquid bottle of morphine. That's not going to end very well, right? Either baby's going to get too much because they're tired of listening to it cry, or baby's not going to get any because mom or dad or whomever is going to use that liquid morphine. So typically these babies are there for a very long time. They will wean them off of the morphine, but sometimes they can be in the hospital for months until they get through the whole withdrawal kind of a thing. Um, Typically, if we would have a baby, um, sometimes if the withdrawals are really bad, um, we'll take the baby to the nursery. Typically, these babies will have some sort of a DCF hold on them. Not always, but sometimes. So then mom is discharged home and baby is left there at the hospital. We'll put them in and we'll leave the lights out in the nursery and baby, mostly all you can do is just sit and hold baby and rock, pat their booty, and try to keep that passy in their mouth, and try to get them through some of this um, with a little bit of TLC. Okay, so still talking about substance abuse, excuse me, in babies. So alcohol or fetal alcohol syndrome. Um, excuse me, I'm so sorry. So things that I might see is microencephaly. So I might have a smaller head. My head may be a little bit smaller than my body. We also saw this with the Zika virus. We saw babies that were born, mom was exposed to that Zika virus from um, mosquitoes. And they had microcephaly, so their heads were much smaller than their body. Um, you'll see growth retardation. Um, the bridge of their nose will be kind of low and flat. The creases of their hands um, may not be normal, maybe a straight line across instead of two lines. Um, they may have a poor suck, some sort of a cleft lip or a palate. Long-term complications with fetal alcohol syndrome is mental retardation. We don't necessarily use that word anymore. We're looking at more of a cognitive delay, hyperactivity, some developmental delays, and attention deficits for sure. They may have some poor coordination. You may still see some facial abnormalities. They may have some irritability and cardiac or joint abnormalities. We don't see this as much as we used to because we're more aware of the risks of drinking, and moms are educated much better when they first become pregnant about alcohol, fetal alcohol syndrome. And please understand, I'm not meaning mom had, you know, drank some alcohol before she found out she was pregnant. This is long-term use of alcohol throughout the pregnancy.